Good evening, everybody. Welcome back to those who came to my first talk. And for those of you who haven't met me before, my name is Gwen Adshead, and I'm a psychiatrist and a psychotherapist. And in this, the second of my talks about changing minds, I want to explore how psychological therapies change your mind. And I'm going to be talking quite a lot about human distress, about mental distress, and some of the common themes. And then I'm going to be looking at perhaps what it is that psychological therapies do when people engage in them, and how they bring about a change of mind. And I wanted to explore this theme because that phrase, changing your mind, is one that we use so easily and so often. And yet, if we think about it, it is absolutely profound idea of that you change your mind. How on earth do you do that? What does that mean when you change your mind? So these are some of the things I want to be talking about, and I want to acknowledge right from the start some very important colleagues whose work has been very helpful to me, and whose work I'm going to be quoting a lot this evening. And they are Professor Anthony Bateman and Peter Fonagy at UCL, and they've done very important work in this area. John Allen from the Menninger Clinic, who was very hospitable to me when I went to visit there, and my colleague Jay Sarkar and Martin Humphrey, with whom I've written some work about psychological therapies. And my dear friend and colleague Maurice Nitzen has also supplied some images for me. So this is Magritte's picture of a mentalizing, meditating person. And I just want to start by thinking, what's wrong with people who are mentally distressed? Now, you might think quite rightly that this is a huge topic, and in a way I'm going to be glossing over it quite lightly. But I want to suggest to you that there are some common themes for what happens when people have psychological distress. So I think that par excellence, we're social animals, we live in groups, but we're also animals that tell stories to each other. So the ability to tell a story becomes a very important part of healthy psychological functioning. And you need to be able to tell a coherent story of yourself in order to live with groups of people. And those groups can be quite small, the family group that you happen to live in, but also much of the bigger groups that we know are a very important part of our social structure. And some of you will know Robin Dunbar's work, who suggests that for most of us, we have a type of social group that extends to about 100 people, if you think about your Christmas card list. Greater or lesser, naturally, but the idea of people that you can be in contact with, but a much smaller group of intimates. But the story of who you are is a very important part of your relationship. And those stories are important because they're means by which we recognize each other across time, but they also allow for change. And if you think about any of you who've been to school reunions or university reunions, will have that thought about meeting someone, he's exactly the same, and yet you know that he is also very different. And you're aware, and if you spend any time talking to your old friend, you will hear something about the ways that he stayed the same and some of the ways that he's different. So in order to tell your story of yourself, you need to be able to organize your thoughts into a coherent narrative. You need to be able to regulate your feelings. And that's quite important because the degree to which you get stressed and aroused is likely to affect the way you tell your story. And probably everybody here in this room has had an experience of being overwhelmed by feeling, so that it was very difficult to think or very difficult to speak. And that ability to regulate your feelings so you don't get overwhelmed all the time is a crucial aspect of the social mind. You need to be able to regulate the distance between yourself and other people. And again, this is something that we take for granted, but that ability to regulate your distance so you don't get too close, but you also don't get too far away, is really quite a subtle capacity, and it's to do with being able to think about other people's minds and to think about your relationship and how you relate to that other person. And that process is something called mentalising, or the idea of reading people's minds. And I'm going to come back to say a bit more about that. So what are the things that people in mental distress, what can't they do? Well, these are a sort of snapshot of you could summarize what people in mental distress, and I'm including people with mental illness labels, which I'm not going to go into. Because I actually think it's more helpful now in the 21st century to think about psychological symptom profiles and what was called in the 19th century phenomenology, what people describe, what people are actually experiencing in their minds. The diagnostic labels tend not to be terribly helpful. But these are some of the problems that people in mental distress describe. So they describe problems in arousal regulation and the ability to soothe themselves. They describe problems in regulating negative feelings, in particular. I've already mentioned regulation of distance and closeness, and often people who are very unhappy in their lives will describe a problem in regulating the distance with other people. Either they feel they get too close and then they have to pull away, or they feel they're too distant. Experiencing an integrated sense of self over time. Again, this is something that, for those of us who have a reasonably integrated sense of self over time, it's hard to imagine what it might be like not to have one. But the sense of feeling fragmented, of feeling in bits, not really knowing whether you're real or not, that's something that people with various types of states of disorder describe, and it's very unpleasant. Disorders of embodiment, and by that I'm really thinking of all the different types of problem that you can have with your bodily experience. And I'd include in there people who have chronic physical symptoms that don't seem to have an illness explanation, an organic explanation. They don't. All the investigations seem to be normal, and yet they have chronic pain, often in the back or the chest or the abdomen, chronic sense of pain. I'd also include the eating disorders in disorders of embodiment. These are disorders very much where distress is located very much in the body. Reality testing deficits, again, that's probably something that we associate with a category of mental illness called psychosis. Psychosis is all about losing contact with a type of social reality, and when you have those types of reality testing deficit, that really alienates you from other people and actually often leads to a type of social exclusion. Thinking errors, jumping to conclusions, black and white thinking, very rigid biases so that you exclude types of information. These are otherwise known as cognitive distortions, and they can happen in all sorts of psychological disorders. They're more common in people who are depressed, but they also in people who are anxious, but we also see them in people who are psychotic. So there's, they come up really whenever people are very anxious or agitated. Dysfunctional time relationships. I sadly don't have time to go into this in any detail, but this is the idea that people who are constantly focused either on the past or on the future have a dysfunctional relationship with their time monitoring. And again, that comes back to the whole, again, which would be a whole lecture in itself, about how we acquire a sense of time and living in time, and how that can become dysfunctional. And then lastly, defects in mentalisation. And that's really what I want to focus on for the rest of the talk, which is about the process by which we read other people's minds, or attempt to read other people's intentions. The process by which we think about other people as having intentions towards us and towards others. And mentalising also includes that ability to self-reflect, to reflect on our own minds. And that process of mentalising is something that we're doing all the time without thinking too much about it. But it's something that comes up particularly, it becomes much more explicit at times when we're distressed. And that mentalising, thinking about other people's minds, is a crucial part of how we maintain close relationships over time. So this is just to remind me to mention a model of the mind that I think is helpful in terms of the evolution of the brain. And Paul MacLean gave us a very interesting, I think, and useful model of the brain, which is, you can think of your brain as being divided into three systems. One, the brainstem, or reptilian brain, which is the part of the brain structure that we share with pretty much all other animals. So this is the part of the brain that regulates sleeping and appetite and breathing and blood pressure and those sort of physiological things. And then the limbic system is the mammalian brain that regulates emotion, and particularly has a powerful impact on negative emotion, particularly around fear and threat perception. And the limbic system is connected to the hypothalamus, which regulates stress responses, helps when we're stressed. It's the hypothalamus that sends out the signals that we should have a fight, flight, and fight reaction. The limbic system is also connected to the hippocampus, which, as I'm sure many people know, is the part of the brain that deals with memory. And then the final part of the brain, called the neocortex, this is the most recently evolved. That other mammals like chimps and dolphins and whales have neocortices, but nowhere near as big as ours, and big in volume. We have huge volume neocortex compared to other mammals. And that is probably related to two things. One, it's related to our group size, the fact that we live in quite large groups, but it's also related to our language capacity. And again, this is Robin Dunbar's work, who's done very interesting, important work showing how the volume of the neocortex is related to language capacity in terms of development. And the key issue here is that there are connections between the cortex and the limbic system. So you might want to think about, we talked about one brain, but there are three types of systems. So we've got an information system, which is organizing knowledge. And we've got an emotional system, which is regulating feelings. And we've got a somatic bodily system. And I'm not going to go through these in enormous detail, but just really to flag up that you could see that you might have disorders in really all those three systems and in the connections between those systems. And this slide is to remind me to talk about defenses. Because one of the things that we have to do in terms of developing our minds, and particularly in the early years, is to develop a way to regulate our feelings and to make sure that we don't get overwhelmed by feelings. And the idea of psychological defenses has been around for about 100 or so years. Starts off in 19th century Germany, developed by Sigmund Freud, but also contemporaneously developed by current writers and theorists like George Vaillant and Phoebe Cramer and Michael Bond. But the point about a defense is that it maintains a type of boundary between your inner world and your outer world. So the boundary between the way you think and feel about yourself and the social space in which you operate. So our bodies and our bodies and the brain as part of the body has different types of system that are activated when we feel aroused or frightened. And again, most people here will be aware of the fight-flight response, which is mediated through your hypothalamus and through your adrenal glands. But then there's a safety activation, which is activated through the parasympathetic system, and that's not conscious. That the drive to feeling secure and safe isn't always conscious. And then there's another part of the nervous system that gets activated when we really think that we're in danger. And that's important for those people who experience life threat and subsequent problems like PTSD. So people who are not able to mount a fight-flight reaction, but instead freeze and become helpless. So the other way to think about this is to think about there's a sort of bottom-up information system which is coming from through what's called the thalamus, which regulates pain and gives us information about whether we're in pain, whether we're in danger, whether we're in stress. And then there's also your frontal cortex, the neocortex, acts as a type of top-down regulator. So basically, your mind and brain, and I can't tell you what the exact relationship is between those things because that's a Nobel Prize-winning question, which I'm definitely not up to tonight. But the point about it is that your brain and mind become activated whenever you feel stressed and distressed, and you're taking information about stress. You become aroused, you become agitated. You get inputs from your frontal cortex which help you to think about the last time you were feeling stressed, to help you take notice, maybe think about ways to manage your distress. And that system is going on all the time. It's a dynamic system. It's going on all the time. We don't even notice it, particularly when we're at rest and we're not feeling stressed or distressed. But the reason I'm laboring this a little is that you can see that there are multiple areas in terms of neural function that can become disordered in terms of stress reactions. And these are just some of the areas that we know are involved when people are distressed. And by distress, I'm including all those types of psychological problems that I was talking about earlier on. So the other way that you could think about this is you could think about there being a problem with your brain function in terms of how you regulate arousal and attention, reality testing, threat perception and pain. And then there's a problem with your defenses, that if your defenses aren't up to it, then you may get overwhelmed by pain, you get overwhelmed by fear, you may get overwhelmed by anger, you may get overwhelmed by feeling tense and wound up. And if you are struggling with those sorts of feelings a lot of the time, then that's likely to send you looking for some type of psychological or psychiatric help. And often if we can't manage our immediate distress, then that's a time when we might behave quite erratically, particularly in relation to other people. And actually, we all know this, because if you're at work or you're visiting friends or family and somebody's a bit irritable with you, one of the first things you'll probably say is, what's up with them? We know that people, particularly people that we like, are often not irritable with us. So to be briefly angry or hostile is often a sign that somebody's inner stress response systems are not working very well. So we might well say, what's going on with him? What's happened? And then somebody will say, oh, well, had a bad day at work, or his mother's just died, or whatever it happens to be. And then we'll say, oh, yes. So we can understand that we might have active stress response systems, and that when we have a brand new stressor, it might take time for people to be able to react. So the problems seem to lie not only in how our brains are managing feelings and arousal, but also in how we see the world, how we make appraisals of what's going on, and actually how we tell a story of that distress can actually profoundly affect how we feel it. So, and particularly how we interpret our bodily experience. So a lot of people who have what are called medically unexplained symptoms, or who have very strong health anxieties, they have a feeling in their body which they immediately interpret as means something is terribly wrong with me. And that's an example of a disorder of the communication between the different types of stress response system. And what happens in therapy often when people come for therapy is they come with a story of what their situation is and how it's come about. And one of the things that people really often want when they're coming for therapy is they want to explore what change would we envisage as being a solution. And often a therapist who's talking to somebody who comes for therapy is going to be saying, what would it take to change your ideas about this situation? What is the change that you want to see in order to make this situation better? Just want to spend a little bit of time about the development of the right brain in particular, because the right brain, we know, has a very important role in modulating negative emotions. And one of the things that we know is that the development of the right brain is hugely influenced by our early attachments to our parents. And this is a picture, obviously, of a child and a mother, but it could equally be a child and a father, that those early attachments are very important for learning how to manage our relationships. But also how we learn how to mentalize, how we learn how to read other people's feelings. And it's in that secure attachment that children begin to develop the idea that they have a mind. And this happens remarkably early, that children as young as 6 weeks can react to what they perceive as being emotional messages from the attachment figure that's looking after them. And they pay very close attention to cues, emotional cues, that are given by carers. And that grows over time through multiple interactions between a child and a carer. What grows is a child's ability to think about itself as having thoughts and feelings. The first steps in what you might think of as metacognition. And if you think about it, it really is an absolutely remarkable thing. And any of you who have children will know that there's a very interesting transition when children stop talking about me and start to talk about I. And that usually ends around the end of the second year. And there's something there about the capacity to think of yourself as being someone who has thoughts and feelings, and by extension, other people as having thoughts and feelings. And certainly some people have argued that that intentional stance, Daniel Dennett's idea of an intentional stance, again is evolutionarily important to us in terms of working out, is this person in my group or not in my group? Are they a predator? Are they an ally? And in certain circumstances, do they pose a threat to me? I won't say a great deal about this, but because it's quite a complicated slide, it's one of Peter Fonagy's slides, but it's really just to point out that actually you can get transgenerational transmission of attachment security. So if a parent has good mentalizing capacities, good abilities to reflect on their own state of mind and on the minds of other people, then they can communicate that to their offspring. And that will increase the chance that their child will also have good mentalizing abilities. And there are a number of studies that have showed that pregnant mums who have high levels of mentalizing have babies who are much more likely to be secure, make a secure attachment, and to be better mentalizers later. And that mentalizing is as I've said before, is a very important part of arousal regulation. So that mentalizing process helps us to regulate our feelings and the degree to which we get distressed. It helps us to maintain relationships because it gives us a way to think about other people's intentions. And it helps develop the coherence of self-narratives, a story you tell of yourself. And this is a quote from a patient of mine who was in a group that I used to run, who talked about he had committed a very serious offence. And he talked about how, in the process of therapy, he came to see that the story that he told about his offence and what he'd done was not the story that he told now, that the story he was able to tell about himself had become sort of deeper, had become more nuanced, had become more elaborated. So to recap, this mentalizing process underpins the social mind. It underpins our ability to have self-other awareness. It underpins capacities to be mindful, to have a theory of mind. It's part of our mammalian heritage, and it has a neurobiological basis. And the reason I'm emphasizing this is because one way to think about what happens in therapy is the restoration of mentalizing. One way to think about what happens when people are psychologically and psychiatrically distressed is that there are failures, catastrophic failures of mentalizing that cause great suffering and also cause real social problems for people. And that many of the therapies that I'm going to be talking about have a focus, maybe not explicitly, on actually improving that capacity to reflect on self and other minds. We know that traumatic experiences disrupt that capacity to reflect. And even in adulthood, adult traumas can disrupt people's capacities to think about their experiences. And chronic fear does that. And it's very interesting, if you look at the narratives of people who've experienced trauma, they often are not able to give very clear accounts of themselves and their experience. And a repeated experience of hostility from other people will also disrupt an ability to think about yourself. Neglect in childhood is a key feature here. And actually it begins antenatally. There's some very interesting research that shows that mothers, pregnant women who experience stress are more likely to have babies who have some degree of heightened stress responses. They're born with babies who are more susceptible to stress. And the mechanism for that, we think, is that the maternal stress affects gene expression in the baby in the womb. And so when the baby comes out and is immediately stressed, because being born is quite stressful, then you've already got a baby who's got a slightly dysregulated stress response system. And that's really quite profound if you think about it. So it's not the passing on of genes so much as the passing that the parent's experience can influence how genes are expressed in children. So and I've talked already about the failure of top-down regulation, an erratic function in the limbic system or the memory system, the hippocampal system, or disorganization of the neural networks that are linking the orbitofrontal cortex, that's the neocortex behind your forehead, and the amygdala and the hippocampus. And you can get disruptions of the function between those parts of the brain, and that will disrupt your stress response system. Because if you can't reflect, you won't be able to see yourself properly, you won't be able to see other people properly, You may become confused about what's real and what's not. And you may be confused about where you end and your body begins and ends, and where other people begin and end. And this is something that we see a lot in people who are chronically violent, where they're really not reading other people's signals and reading other people's minds very clearly. And I'm going to be talking quite a bit more about that in my next lecture. And some of you will recognize this wonderful quote by one of our earliest psychologists: "How do you see the world with no eyes? I see it feelingly." And that notion of that we experience the world through our feelings and our reflections on our feelings. So what would help? Well, better affect and arousal regulation will help when people are in distress. A better understanding of stress and distress will help. Actually, just giving people information about how stress systems work. A better awareness of yourself. And that, of course, is a process that can sometimes take quite a bit of time. Becoming really aware, taking time out to be aware about how you function in the world and how others see you and how you see other people. But that awareness can take some time. Also becoming aware of what you don't let yourself think about. And this is one of the hardest things in terms of psychological change, because most people come with quite rigid set of beliefs about the world. And often within those rigid set of beliefs, they exclude a lot of information about how the world works and about particularly how other people work. So one of the first things that is important for psychological change is to work out what you're not thinking about. And of course, that has that paradoxical difficulty about how can you think about what you're not thinking about. The other part of psychological change is an invitation to, could I change the way that I look at myself? Could I change the way that I see this problem? And and one of my old teachers used to say the whole of psychological therapies could be summed up in the question, is there another way to think about this? And that actually is a very important question, because with that question comes a curiosity about whether things could be different. And that is crucial to psychological change. These are Professors Anthony Bateman, Professor Peter Fonagy, who I mentioned, who've done an enormous amount of work on mentalisation, mentalising capacities, how they develop in children, and about how you can use them in therapy. And the reason what I'm going to do now is just talk a little bit about mentalising-based therapies, because these are therapies that really focus on how people think about their minds and the minds of others. It's based on attachment theory that I've already mentioned and evolutionary psychology. And as I say, it's about developing people's capacity to keep mind in mind, to become more aware of other people's intentions and experiences, and becoming more aware of their own. So there are different ways that mentalising can go wrong. You could have distorted mentalising, where your imagination goes wild, and often when people are paranoid, this is what happens. People start to elaborate and make stories. People who are anxious. And again, probably everybody in this room may have had an experience of feeling anxious about something, and you start a chain of thought about what if this happens, what if that happens, and before you know it, you've elaborated quite a big story about what might happen and about what terrible things could happen. And that's your mind getting ready for a threat. But of course, if you get stuck in that future narrative, that future fearful narrative, that can actually stop you from making good use of the present. And similarly, in the past, you can get caught up in ruminating on the past, and that can fix you in a way that means that you can't change, makes psychological change difficult. And then there are situations where people aren't mentalising at all. They're sort of blocked, and we see that in people who just, I'm not thinking about this. I don't want to think about this. I don't have a problem. I'm not engaging with this. And we sometimes call that mind blindness, or something about just not taking the mental experience seriously. And we sometimes see this in people who are stuck in what I think of as predator mode. Again, that's thankfully not very common, but that's a state of mind where you're really not very interested in what other people think. This is one of my favourite slides, and I apologise if you've seen it before. Yeah. If only it were true. So again, just to recap, these are what I think are the commonest symptoms of mental disorders and mental distress. I've already gone through some of those: poor arousal regulation, embodiment, poor affect regulation, so that people self-medicate with substances, and that of course creates a whole new problem. And often when people come to see a psychiatrist or a psychotherapist, what they're coming with is really the secondary problems associated with managing problems with affect and arousal regulation. And self-medication with substances obviously causes enormous difficulties. Poor interpersonal skills, social exclusion, social isolation. So many people with mental disorders describe a sense of social isolation, feeling excluded. And of course we know that the stigma of mental distress means that people don't talk about their distress. Still in 2016, still quite a lot of stigma about mental illness and mental distress. People feeling really alienated, or else being quite paranoid about the social world. And if you're paranoid about others, then that increases your chance of acting in a hostile way. And again, I've talked about failure of reality testing. The capacity for reality testing is very precious, and how it develops is not well understood. But if you can't test social reality, if you can't maintain a curiosity, if you can't tolerate being uncertain about what's going on, then that can be a real problem, because so much of our social life involves complexity and ambiguity and uncertainty. And if you can't tolerate the anxiety that goes with uncertainty and ambiguity, then you're likely to adopt a slightly unreal position, which can cause further problems. So what happens in psychotherapy is that we restore or improve mentalizing by challenging thinking errors and fix dysfunctional beliefs. We try and reduce the tendency to act on distorted thoughts or feelings. We try and improve people's mood regulation and helping people cope with painful emotions better. We try, and really this process starts with raising awareness, with just helping people become aware of what it is that they're thinking and feeling. And often that may be related to experience of dysfunctional relationships with other people. And also we spend quite a lot of time thinking about time perspectives. Again, many people who come in distressed states of mind are quite either fixed on the future or the past. And often a lot of what we do in therapy is help people be grounded in the present moment. And what's interesting about that is that view of being grounded in the present moment is actually something that people have known is psychologically important and associated with psychological health. We've known that actually for centuries. And you can find that in the contemplative literature from a number of cultures. And I don't have time to talk about that in any greater depth, but it is remarkable how much that present moment awareness is a crucial part of mental health. So all the psychological therapies that are out there really do these things. They try and help people understand themselves better. They try to encourage people not to avoid or push away distress, but actually to get real with it, to take it seriously, to be present, to allow the reality of distress to be present. We try and help people understand how anxiety and distress distort thinking, because this is such a common part of people's distress, is fixed beliefs that underpin their distress. But also the other way is that negative thoughts can actually drive distress. If you have lots of negative critical thoughts, and we all have self-critical thoughts from time to time, but there are some people who have become quite preoccupied in criticizing themselves, and a very persistent critical ruminatory state of mind can actually drive your mood down or make you very anxious. And people who are anxious, again, would prefer to develop fixed beliefs about themselves rather than be anxious. So often in therapies we're helping people gently to just take apart some of their fixed beliefs about the world and try and move people from a sense of helplessness and hopelessness into a position where they feel more able to take steps, to change things. Many people come for therapy describing a sense of hopelessness and helplessness. And sometimes that makes, if it's to do with past traumas or past stresses or past disasters, then we're not talking obviously about changing the past. But a key issue is changing your relationship with the past and how you think about the past. And that's something that most of the therapies, psychological therapies that are out there, encourage people to do. But there are a number of difficulties about this. One is that most psychological therapies take time. There are brief therapies out there of 6 weeks, 8 weeks for fairly minor anxieties, and it's remarkable how effective they are actually. And there is brief cognitive behavioural therapy, even some computer-based cognitive therapy can be quite good for sort of fairly mild anxiety problems. But for people who've got more severe or complex problems, and particularly people who've experienced complex and chronic trauma, they're likely to need quite long-term therapy. And 18 months comes up consistently in the literature as being the length of time that people need. The process of psychological change can be painful and scary. It's not necessarily anything, it's not a comfortable process, changing your mind. And that's quite important because sometimes people think there's a fantasy that coming for psychological therapy is going to make people feel better. And in the long term, it may make people feel better, or at least feel differently. But in the short term, psychological therapies, the process of psychological change can be quite painful and uncomfortable because it means trying something new or thinking something new, and that in itself generates anxiety. You also need to have trust in the person that you're working with, and developing trust takes time. Even if you're a reasonably securely attached person with good mentalizing skills, to trust a therapist with a delicate problem takes a number of weeks. Very properly don't trust people just at first sight. And for people who've got complex traumas, people who've come from environments where they've experienced extremes of childhood adversity, takes months to generate trust. And when I used to work in a maximum security hospital, and I used to think it took about a year for the guys that I worked with there to learn how to trust me. And the other thing is that psychological change can have unforeseen consequences. You may find that the way that you see the world and the way you make choices is different, leads to a new way of engaging with other people. And that can have knock-on effects on your relationships with other people and the way that you work and the way you engage that you can't anticipate. Some people in your social world may not recognize you in your new incarnation, as it were. So there can be unforeseen consequences that are literally unforeseen, but they may take you by surprise. And this is one of Morris Nitson's beautiful pictures. So here are some of the therapies that are currently available for mental distress. Why they have to be three-letter acronyms, nobody knows. The CBT, cognitive behavior therapy, DBT, dialectical behavior therapy, MBT, mentalization-based therapy, SFT, schema-focused therapy, TFP, transference-focused therapy, mindfulness, and ACT, that's acceptance commitment therapy, which is often part of DBT, POT, this is John Allen's nice acronym for plain old therapy, that's just going and sitting down, and I added the one at the end. So this is, and people often say, quite rightly, that this is very confusing, and how on earth do you know, if you're seeking therapy or advising people about therapy, how do you know what's right for people? And actually, this is really still, we don't actually have good, really good answers to what works for people. And the chances are that the different types of therapy work in different parts of your brain. And it may well be that you need different types of therapy at different times. So quite often when I'm working with someone with complex needs, I might start them off with some psychoeducation and cognitive therapy to help them regulate their anxiety. And then I might encourage them to do some mentalization-based therapy to think about their relationships with other people. But, that's based on my clinical experience. I don't have a research protocol to underpin that. So do the psychological therapies work? Well, there's plenty of evidence that they do work. Of course, it depends a little bit on what you mean by work. But is there evidence that psychological therapies change the brain? Absolutely. And that's partly because your brain changes every time you learn something new. Hopefully your brain will have changed a little bit at the end of this lecture. But any new learning brings about a change in brain structures. And we know that from the work of Eric Kandel, that the learning of new information actually causes a change at a neuronal level, and through an impact on gene expression. Remarkable work. And that new information affects how neurotransmitters are released or processed. So what you learn affects the way your brain works, which affects the way your mind works. So we know that psychological therapies have an impact on how the brain works. It's not, quotes, just talking. It's actually having a direct effect on your brain. And this is a picture of people in two types of therapy. So the people at the top are having cognitive behavioral therapy, and the people on the bottom are having paroxetine, which is antidepressant. And the red blobs, which you probably can't see very much, are about an increase in brain activity, and the blue areas are about a decrease in brain activity. And really, there are two take-homes from this, is that both pharmacological therapies and psychological therapies change your brain, but the ones with eagle eyes will be able to see that the pattern of change is different. So the way that paroxetine changes the brain is not the way that psychological therapy changes the brain. And that's what in a way, that's what you'd expect. You'd expect that there's no particular reason why they should work exactly the same. But there is much, much more research to do in terms of understanding how psychological therapies change the brain and what works best for what. And as you know, antidepressants can be very helpful in helping people feel a bit more stable in their mood regulation, but they only work for about 65% of people who prescribe them. There's a group of people out there for whom they don't work at all. So what do the therapies do? So all the therapies support some type of enhanced mentalizing, either implicitly or explicitly. And if they're effective, what people come out of an effective psychotherapy saying is that they feel more able to make decisions for themselves, an enhanced sense of agency, a more nuanced type of narrative about themselves, and often a decrease in the negative behaviors that caused them problems in the past. And the therapist needs to be consistent, patient, empathic, attuned. And this quote is from somebody who went through a period of group therapy. And they were asked at the end whether psychotherapy had changed them, and they said, "I'm still the same person, I just think completely differently." And that is a nice summation, I think, about what psychological therapies do. And we pay a lot of attention to language. The minutiae of people's language is important. This is a quote from a therapy session that I did. I was working with a young woman who killed somebody, and she said, "I just have to pick up the pieces and go on." And I noted her use of the metaphor pieces, and I said, "You were in pieces." And she responded by saying, "After she died, I was shattered, completely shattered." So she'd moved from a sentence which had a little bit of a sort of feeling of, wasn't really saying anything about herself very much, wasn't really saying very much about her state of mind. But by focusing in on her language, and particularly her metaphorical language, could move her to being able to say a little bit more about how she felt, how she actually felt. And of course, the experience of feeling shattered is very distressing. So I'm just going to close with a few more thoughts about the therapist. I never thought of myself in this way, but now I never stop thinking about myself in this way. And I must purchase a bowler hat, clearly. What are the blocks to therapy? Well, getting people engaged in therapy is often the biggest problem. Quite a lot of people come for therapy, but often getting people engaged, and that's something to do with expectations too. Sometimes people come with very unrealistic expectations about what therapy can do for people, and that can lead to ruptures in the therapeutic alliance. And sometimes people who've been caught up in very hostile and preoccupied types of attachments with other people will repeat those patterns with the therapist, and then they drop out of therapy, and it's not possible to explore a new way of relating. But the therapist brings some problems as well. Therapists are people too, and they come bringing all sorts of feelings to the therapeutic encounter, and therapists can behave in ways that don't help the mentalizing process. So sometimes therapists can be appeasing when they should be challenging, they can be rejecting when they should be validating, they can be helpless when they need to be active. So engagement is really the key issue, because we know that failure to complete psychological treatments is common. Now, actually, that's exactly the same for pharmacological treatments, in fact. The ability, people just don't finish treatment, whether it's antibiotics, antidepressants, or a course of psychological therapy. People often, they don't complete. And failure to complete can be associated with a worse outcome than if they'd never started. So we really want to try and stop people from disappearing. So we need to be able to improve engagement, which often means about trying to get people ready for therapy and helping therapists to be prepared to help people. And on that note, I'm going to close and see if we have time. We have a little time for some questions.